Welcome to the Veterinary Research Channel and to our discussion on cancer chemotherapy. This playlist provides a foundational overview of how chemotherapy works, the complexities of its administration, managing side effects, and the various types of drugs used. We'll explore everything from the basic science of how these drugs target cancer cells to practical considerations like dosing and safety. We'll also touch upon key terminology, discuss how we manage toxicities, look at mechanisms of drug resistance, and delve into the specifics of several important drug classes. Finally, we'll consider prognostic evaluation and future directions in this field. Let's start with the fundamental principle. How do these drugs work?
Absolutely. The fundamental basis of anti-cancer drug activity is the targeting of dividing cells. This is achieved by interfering with processes essential for progression through the cell cycle. The key phases targeted include the S phase, which is dedicated to DNA replication, and the M phase, where cell division, mitosis, occurs. Beyond these phases, a newer class of drugs, signal transduction inhibitors, works differently. They interfere with the signaling pathways that trigger cells to enter the cell cycle in the first place and continue proliferating. Focusing on the traditional cytotoxic drugs, a primary target is DNA synthesis, a complex process. This involves the anabolic creation of the necessary purine and pyrimidine nucleotide triphosphates required for replication. It also includes the unwinding of the template DNA so the replication machinery can access it, and the crucial, high-fidelity process of creating complementary DNA strands. Anti-cancer drugs intervene at all these levels of DNA synthesis. For instance, antimetabolites inhibit the anabolic processes needed to provide the nucleotide building blocks. Topoisomerase inhibitors interfere with the enzymatic unwinding of DNA. Cross-linking agents, through interactions within or between DNA strands, block the processes of strand separation and template processing. Alkylating agents interfere with the replication machinery itself via multiple mechanisms, altering binding and base recognition. The ultimate consequences of these interactions with DNA replication processes can include the generation of DNA strand breaks, incomplete replication, and the triggering of apoptotic signaling, leading ultimately to cell death. Cellular response can manifest in various ways, including mitotic catastrophe, apoptosis, necrosis, autophagy, or cellular stasis. This response depends on a complex interplay of survival and death signaling pathways and is often specific to the particular agent, the dose reaching the critical target, and the cell lineage. Alterations in pro-apoptotic and anti-apoptotic signaling are known to play a role in both tumor development and response to therapy. Specifically, anti-apoptotic signaling mediated by BCL2 and survivin appears particularly clear in lymphomas regarding both chemosensitivity and response in humans and dogs. However, the precise role of damage response and active cell death pathways in chemotherapy sensitivity and response for solid tumors is still being investigated.
That provides a solid basis for how the drugs work. Now, let's dive into some of the essential terminology and concepts used when discussing cancer chemotherapy. Understanding these terms is crucial for grasping the pharmacological activity, especially concerning efficacy and toxicity. One important term is the therapeutic index. This is typically defined as the ratio between the toxic dose and the therapeutic dose for a drug. However, for most cytotoxic chemotherapy drugs used in cancer treatment, the therapeutic index is more of an abstract concept. This is because the dose administered is generally based on the maximum tolerated dose, or MTD, rather than being derived from a dose-response assessment focused on efficacy. The MTD is an empirically derived value. It represents the highest dose of a specific drug that can be given to a limited sample population without causing unacceptable or irreversible side effects. This is a critical concept in cancer drug administration, as dosing decisions are predominantly based on this MTD value, rather strategic assessments of efficacy based on dose. A newer concept, particularly relevant for signal transduction inhibitors and molecularly targeted agents, but not exclusive to them, is the biologically effective dose, or BED. The BED is based on a measured response at a putative target or surrogate marker that is linked to the drug's mechanism of action. Using the BED concept might be valuable when applying cytotoxic chemotherapy with dosing protocols that aren't strictly based on MTD. We also need to understand dose intensity, or DI. DI is a measure of the dose per unit of time. This metric allows us to compare different dosing schedules, such as administering a drug every 3 weeks versus every week. Comparing DI can help determine whether the total dose of a drug or the dose intensity itself is more related to toxicity or the therapeutic outcome. It also highlights how altering dosing schedules can impact the outcome. When combining two drugs, or combining chemotherapy with radiation therapy, we often evaluate therapeutic gain. Therapeutic gain quantitatively describes any improvement in tumor response relative to any increase in toxicity in normal tissues when these agents are used in a planned schedule. A positive therapeutic gain is achieved when the additive or synergistic effects on the tumor are greater than the summative toxicity patterns observed in normal tissues when combination therapy is used. Beyond these quantitative terms, there are concepts describing the timing and purpose of chemotherapy within a treatment plan. Adjuvant therapy involves chemotherapy given after the primary tumor has been surgically removed or controlled by radiation. Its purpose is to treat any occult disease, cancer cells not clinically detectable, and usually involves systemic drug exposure. Primary or neoadjuvant therapy uses chemotherapy before other modalities, typically surgical removal of the primary tumor. The goal here is to decrease tumor size to improve the chances of control and prevent the possible postoperative growth of tiny undetectable metastases. Induction therapy is similar to neoadjuvant therapy, but specifically refers to the initial phase of drug treatment aimed at achieving remission in lymphoid or hematopoietic cancers. Maintenance therapy involves ongoing chemotherapy to maintain a state of remission. Consolidation therapy is intended to sustain an achieved remission. Rescue or salvage therapy is used when a tumor has failed to respond to a previous treatment or when the tumor has recurred. Palliative chemotherapy is given with the goal of decreasing clinical signs in cases of unresectable or widespread disease that cause functional disturbances or pain. The outcome of palliative therapy is evaluated more on quality of life issues rather than objective tumor response metrics. The subjective nature of assessing the effect, especially pain control, makes systematic testing of palliative protocols challenging, often leaving treatment decisions more to the clinician's discretion and the client's goals. However, if tumor growth impacts organ function, objective endpoints like improved functional capacity might exist. Dosing and scheduling for palliative therapy may also differ, as strict adherence to protocols developed for objective response trials may not be relevant. Finally, radiosensitization refers to the enhancement of chemotherapy-induced cytotoxicity when irradiation and chemotherapy are combined, resulting in a therapeutic gain. The mechanisms behind chemotherapy-enhanced radiosensitivity are multifaceted.
Understanding these different types of therapy and assessment metrics is really important for putting treatment plans into context. Now, let's talk about the practical side of administration and dosing. The traditional convention for drug dosing in veterinary medicine is to normalize the dose based on the patient's body surface area, BSA, typically expressed in milligrams per square meter, mg/m superscript 2. This approach is based on the idea that BSA correlates with drug distribution and/or elimination, aiming for consistent drug exposure across individuals. However, it's worth noting that there isn't always data to directly support this relationship between drug exposure and BSA for every agent. There are exceptions to the BSA paradigm. For dogs weighing less than 15 kilograms and for all cats treated with doxorubicin, dosing is based on body weight, mg/kg. This modification stemmed from empirical evidence suggesting a better toxicity profile for smaller dogs when using mg/kg dosing for doxorubicin. Unfortunately, a uniform dosing model hasn't been established, so dose adjustments are often necessary after the initial doxorubicin dose. Despite these conventions, significant pharmacokinetic variability can occur in a patient population undergoing cancer chemotherapy. Numerous factors contribute to this variability. These include concurrent illnesses or organ dysfunction and extreme tumor burden, specific breed sensitivities, like collies with an ABSP1 mutation, or idiosyncratic factors, such as anticipated drug-drug interactions or drug allergies. Concurrent illness and organ dysfunction can significantly affect both the selection of anti-cancer agents and their dosing. Generally, predictable dose adjustment guidelines for pets with renal or hepatic disease haven't been fully developed, so treatment in these cases requires a conservative approach. Interestingly, in cats, the glomerular filtration rate, GFR, can be used to define an individualized dose for carboplatin, allowing some cats with renal disease to be safely treated when conventional methods might not be safe. Dose adjustments of 30% to 40% are recommended for drugs that are substrates for the ABSP1 transporter in collie-type breeds confirmed to have the ABSP1 phenotype. Even dogs with a heterozygous ABSP1 phenotype might require dose adjustments. The question of chemotherapy dosing in obese patients also arises. While distribution of many pharmaceuticals can be affected in obese human patients, there isn't a universally accepted scale for empirical dose adjustments. Some reviews suggest that dose reductions based on body mass might actually be detrimental to outcomes in obese patients. Clinicians may decide to reduce or cap the dose based on individual factors like the specific drug, degree of obesity, and other comorbidities. It's emphasized that the initial chemotherapy intervention is the best opportunity to benefit the patient, so careful patient assessment and designing a therapeutically robust protocol are highly desirable. Optimizing the delivery of cytotoxic therapy relies heavily on achieving optimal dose intensity. This necessitates therapeutic monitoring to guide dose adjustments, either increasing or reducing the dose, based on the patient's ability to maintain a good quality of life during effective treatment. The decision to increase a cytotoxic dose can be conceptually challenging, but is important. To recommend a dose increase, owners must understand and monitor the patient's white blood cell values and clinical events during the first treatment cycle. A cytotoxic dose that doesn't cause any change in the target normal tissue, such as the blood neutrophil count, is likely ineffective and could be increased by 10% at the next infusion with continued follow-up. Conversely, dose reductions, while anticipated, are considered deleterious to optimal chemotherapy delivery. Standardized guidelines for antineoplastic dose adjustments are lacking. Generally, a 20% to 25% reduction in the subsequent dose is recommended for patients experiencing moderate or severe dose-limiting toxicity, such as neutropenia or vomiting. Close monitoring and preemptive management of signs can help manage some potential future clinical issues. Clinical decisions for dose adjustments are ultimately based on the extent and severity of resulting signs.
Managing side effects, or toxicities, is indeed a critical part of chemotherapy. Cancer chemotherapy can fail to provide clinical benefit not just from lack of efficacy, but also due to unacceptable toxicity. Anticipating and managing these adverse events requires a thorough understanding of the drug's activity profile and clinical experience. A fundamental first step is always a clear and open discussion with the owner about the potential for benefit, toxicity, cost, and time commitment. Establishing a common understanding of treatment goals and maintaining ongoing communication is invaluable. We can categorize chemotherapy toxicities based on their timing relative to treatment. There are immediately evident toxicities occurring at the time of treatment or within 24 to 48 hours. Examples include infusion hypersensitivities caused by histamine release, like with L-asparaginase, or vehicle-induced mast cell degranulation, seen with paclitaxel, etoposide. These can often be managed or prevented with routine pretreatment using antihistamines and steroids. Acute nausea and vomiting can also be immediate, sometimes linked to specific agents like cisplatin or a rapid infusion rate like with doxorubicin. Preemptive antiemetic management is effective here. A serious immediate concern is extravasation for drugs with vesicant properties, meaning they can cause moderate to severe tissue necrosis if they leak outside the vein. Vinca alkaloids and doxorubicin extravasations are particularly severe and should be avoided. This might necessitate sedation for proper catheter placement or even rescheduling treatment. Owners should be informed about this possibility and a management plan developed. Management involves stopping the infusion immediately, aspirating residual product from the catheter, and removing it. For doxorubicin extravasation, dexrazoxane, Zinacard, can be used, often at 10 times the doxorubicin dose infused within 3 hours, with potential additional infusions at 24 and 48 hours. Identifying a source for dexrazoxane beforehand is wise. Despite active management, severe doxorubicin extravasations can lead to extensive tissue necrosis, potentially requiring surgery or even amputation. The second category is acute delayed effects, which typically appear 2 to 14 days after treatment. The most common of these include bone marrow suppression and nausea, vomiting, and diarrhea. In most cases, these effects are self-limiting and hospitalization is infrequent. For neutropenia, which is defined by low neutrophil counts per microliter, management depends on severity. 4 counts of 750/L, grade 2/mild. Oral broad-spectrum aerobic antibiotics are recommended, with a follow-up CBC in 2 to 3 days, and hospitalization is not needed. 4 counts below 500/L, grade 3/moderate or grade 4/severe. Antibiotics, oral or 4 if febrile, are needed, CBC in 24 hours, and hospitalization is required if the patient is febrile. Broad-spectrum anaerobic antibiotics are not routine unless the neutropenia is refractory to aerobic antibiotics. Parenteral fluids might be used if the patient is febrile. For nausea/vomiting, graded by frequency, treatment involves antiemetics. H2 blockers or proton pump inhibitors may also be used, particularly if there's a history warranting prophylaxis. Parenteral fluids are indicated as needed, and hospitalization is required for severe cases. Diarrhea is graded by number of stools over baseline. Management involves diet adjustment and antidiarrheals. Parenteral fluids are indicated for moderate or severe diarrhea, and hospitalization for severe cases.
That covers the immediate and acute delayed effects. The third category of toxicity is cumulative/chronic toxicity, which develops over weeks, months, or even years. Examples include hepatic dysfunction after multiple doses of agents like CCNU, lomustine. There are also cardiac abnormalities that can occur after exceeding a safe cumulative dose of doxorubicin. Renal disease is another chronic toxicity associated with cisplatin use in dogs or doxorubicin use in cats. Strategies and screening recommendations have been developed to reduce the risks of these chronic effects and are incorporated into standard protocols. It is absolutely critical that owners are thoroughly informed about monitoring guidelines for general signs and symptoms of chemotherapy toxicity. Providing owners with resources, such as online educational materials, is helpful. It's advisable to instruct owners on how to monitor and recognize early signs like nausea, vomiting, diarrhea, or hematuria, and importantly, how to obtain an accurate body temperature. These at-home monitoring aids empower the clinician to assess management options promptly if a concern arises.
Beyond managing the patient's response, chemotherapy effectiveness can be limited by drug resistance. This is a significant challenge in cancer treatment. There are several mechanisms by which tumor cells can become resistant to chemotherapy. One key mechanism involves alterations in drug uptake. Some drugs rely on specific transporters to enter cells, and changes in these transporters can lead to resistance. For example, decreased uptake of meclorethamine has been identified as a resistance mechanism. Similarly, melphalan is actively transported into tumor cells by amino acid transporters, and its uptake can be blocked, affecting sensitivity. Another major mechanism of acquired resistance is modifications in the cellular target of a given drug. This can involve mutations in the target protein that lead to decreased drug affinity or prevent the drug from interacting effectively. It can also involve changes in the levels of the target protein. Decreased levels of a specific target responsible for generating a toxic product can lead to resistance. Conversely, increases in target levels can allow cells to overcome the inhibitory effect of the drug. Examples include decreased topoisomerase I-alpha levels playing a role in resistance to doxorubicin and epipodophyllitoxins like etoposide and tenofovir. Increased levels of thymidylate synthetase correlate inversely with sensitivity to 5-fluorouracil, 5-FU. Target amplification, such as a methotrexate resistance where gene amplification leads to increased dihydrofolate reductase, DHFR, levels, allows cells to overcome DHFR inhibition by methotrexate. Mutations in targets like beta-tubulin, affecting paclitaxel binding, and topoisomerase I, affecting camptothecin binding, also lead to resistant tumor cells. These examples show that resistance can arise from both quantitative changes, level of target, and qualitative changes, mutation of target structure, in the drug-target interaction.
That's right. Another mechanism of acquired resistance involves alterations in metabolic or detoxification pathways within tumor cells. Many chemotherapeutic agents are electrophilic due to their DNA binding properties. Therefore, enhancing conjugation reactions with nucleophiles like glutathione is a plausible mechanism of resistance. Induction of glutathione S-transferases has been shown to cause acquired resistance to nitrogen mustards. Although tumor cells generally have limited drug metabolism capabilities, some metabolic pathways significantly contribute to resistance. For example, tumor cell sensitivity to 5-FU is inversely correlated with the expression of dihydropyrimidine dehydrogenase, DPD. DPD is the primary enzyme responsible for metabolizing 5-FU into its inactive metabolite, 5-FUH2. For prodrugs like gemcitabine, which must be phosphorylated into active forms, D, and triphosphate. To inhibit DNA synthesis, resistance can occur if the activating enzyme is downregulated. For gemcitabine, the enzyme is deoxycytidine kinase. Decreased levels of this enzyme have been shown in pancreatic tumor cells made resistant to gemcitabine. This interplay between metabolic detoxification, inactivating the drug, and activation, making a prodrug active, can lead to complex scenarios, particularly with nucleotide analogs, involving the upregulation of catabolic processes and downregulation of anabolic processes that affect the drug's cellular pharmacology. Perhaps the most well-known mechanism, especially for multidrug resistance, MDR, involves the expression of adenosine triphosphate, ADP, binding cassette, ABC, transporters. These transporters play a primary role in actively pumping drugs out of cells. There are 48 known ABC genes in the human genome, and 15 members of the ABC transporter family have known chemotherapy substrates. Well-studied examples include PGP/MDR1, ABSP1, MXR/BCRP, ABSG2, MRP1, ABCC1, and MRP2, ABCC2. The core function of ABC transporters is conserved. They use ADP energy to transport xenobiotics and endogenous substrates from inside the cell to the extracellular space. The role of ABC transporters in multidrug resistance in canine and feline cancers is still under investigation, but ABSP1 is expressed in canine lymphoma, canine mammary tumors, and canine and feline primary pulmonary carcinomas. Studies are also exploring the normal tissue distribution of ABC transporters in dogs, showing similar patterns to humans, but some differences in relative expression. Interestingly, feline ABSG2 has specific amino acid changes that lead to dysfunction for some substrates, suggesting potential altered drug disposition in cats. That covers this portion, or Episode 1. Next episode, we will get into specific chemotherapy drugs.
And don't forget to like, share, and subscribe, as 50% of all proceeds generated from this channel will be donated towards animal care. Thank you, and as always, keeps those minds inspired, hearts light, and tails wagging.